to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Associate Professor of Nursing at Salisbury University and host of the program. My guest, of course, you're a return guest, is Dr. Richard Bird from Riverside Neuralgia Associates, located here in Salisbury. Welcome back to the program.
Thank you.
The topic for this program is trigeminal neuralgia. Now that's a mouthful, so I think first things is to just explain what those two words mean and then tell us a bit about the disease and how common it is.
Well, as much of a mouthful as trigeminal neuralgia is, it's better than its original name, which was known as tic douloureux, which is in French because nobody knows for the most part what that means. A trigeminal neuralgia is by definition a neuralgia involving the trigeminal nerve. The trigeminal nerve is a large nerve that comes off the base of the brain in an area called the pons. It's kind of the bottom part of the brain that connects the upper part of the brain to the spinal cord, where most of the nerves to the eyes, the face, the throat, the hearing, everything come off. The trigeminal nerve is the biggest of these, and it comes by what you would assume by the name in three large branches. It sort of comes out like so. And there's an upper branch that comes out just above the eyebrow and feeds this part of the face and the eye. The second branch comes out just below the eye into the sinus and feeds the lower part of the face and up to the nose, the upper lip, and the upper teeth. The third branch then feeds the jaw, comes down through, feeds the lower teeth and the inside of the mouth and the jawline. So of the three branches, they each go to different parts. Most people learn about the trigeminal nerve when they go to the dentist and have a block with a xylocaine to numb it. They're numbing the trigeminal nerve because that feeds the teeth. So dentists frequently involve the trigeminal nerve in their daily routines too, and sometimes are the ones who send us the patients because the patients come in with pain in those areas that turn out not to be dental but the nerve itself.
Now the nerve is called trigeminal. Now what's neuralgia mean, the second part?
Neuralgia means pain in the nerve. Neuritis means inflammation of the nerve. Neuralgia, anything with an algia at the end of it, is a Latin word for pain. So that's nerve pain, essentially.
But it's localized, obviously.
Yeah, and just this nerve, right.
Now first, before we get into the actual, what happens to create this problem, how common is it? Is it something you commonly see in your practice?
Yes, actually it's quite common, mainly of older individuals. We see it occasionally in young individuals. Some of them have multiple sclerosis as the cause of it. But it's very uncommon in younger individuals. So we see it primarily in older individuals. And by older, I mean late 50s, early 60s on up. And there's a reason for that because the number one cause of it tends to be high blood pressure. And the reason that that's a common cause is over time, with your blood pressure being too high, it pounds on your blood vessels and gradually begins to distort them and distend them into a little bit different shapes than they used to be in. So when an artery used to be fairly straight, over time with pounding it may start buckling and leaning. And what does it lean against? Well, whatever happens to be in the neighborhood. And the trigeminal nerve, being a big nerve, often is in the neighborhood. So what happens is one of the major arteries, or primarily one of its side branches, starts leaning on the nerve, and the pulsations of the blood pressure going through that artery eventually start wearing through the coating of the nerve. Think about a wire with a coating on it that you finally crack the coating, it starts shorting it out. The same thing happens with the nerve. The blood vessel pounding into the nerve eventually starts breaking through the coating or irritating the coating enough that you finally start irritating the nerve root as it goes through there, and you start getting nerve symptoms depending on which division of the trigeminal nerve you're on.
Now, if someone controls their blood pressure with medication and whatnot, then they'll be less likely to get the trigeminal?
Much less likely.
Okay,
yeah.
That's good to know.
That is the number one cause of it by far.
Untreated or undertreated hypertension.
And even some people were treated. Some people just have this happen to their blood vessels over time. Even people who are fairly well treated will have this happen.
Now, what exactly are the symptoms? Now, obviously, some kind of pain, but tell us a little bit more about that.
It's a very unique set of symptoms, actually. It's about the only condition involving the nervous system that acts like this. It's what they call severe lancinating pain. And by that, it means it's like an electric shock, like somebody took a live wire and plugged it right to the side of your face and touched you with it for a moment. It's like a zap. And it just, is really very painful.
So
and it can be very repetitive.
A jolt of excruciating pain.
Yes.
In the face somewhere or anywhere around the face?
Depending on which branch you're in. If it hits the top branch, which is the least common, you get pain in the eye and the forehead. If you hit the second branch and the third branch, which are the two most common, but the second branch is the most common, you often get pain around here, around your upper lip, upper teeth, inside the jaw, and cheek. And in the lower branch, you get this lancinating pain in the jaw and the lower teeth. It often is triggered by any kind of things that would affect sensation. The trigeminal nerve is a sensory nerve. It feeds the feeling from your face back to the brain. It has no real motor component. It does feed a little bit of muscles in the jaw, but most all of it is sensory. So you can get terrible sensory pain. So anything that triggers sensation can trigger the symptoms.
So can it be touch or cold?
Touching your face, washing your face, brushing your teeth, putting on makeup, shaving, talking, yawning, eating. Some people, cool breezes, hot breezes, anything kind of temperature change may set this off. I have a few patients that I know when they come back, when the pain is acting up, they come in with a beard. I know they're not shaving anymore because it hurts too bad, that we need to get their neuralgia back under control. Because some people, anything that stimulates that nerve will set this pain off. And it tends to be episodic. It's not constant in most people. It's very episodic. But just in the act of trying to chew your dinner can cause such severe pain that a lot of people stop eating and lose weight and sometimes wind up dehydrated in the hospital because they can't eat. It hurts so bad.
So this can lead to some serious problems.
Yes, that being the most common of the serious problems is people can't eat and drink and they begin to become malnourished and dehydrated because it just hurts so bad.
Now you're saying it's pretty rare when it's up in this part of the face?
You don't see it much in the top of it.
I would imagine that could be confused with a migraine or something, could it? Or
occasionally, or sinus infections.
Okay.
They have sinus infections occasionally get misdiagnosed with this condition, or something wrong with the teeth. They say that's why the dentists get involved. People come to them because their teeth hurt, and they start sometimes actually getting teeth pulled. And that isn't the problem. It's the nerve to the teeth causing the pain in the teeth, not the tooth itself. But some people have both problems, so they lose their teeth because they've got bad teeth, but that didn't get rid of the problem.
Now, is this diagnosed primarily by symptoms, or is there any tests you can do?
Primarily symptomatic, yes. We often get MRIs of the brain, often with contrast, to take a look to make absolutely sure there's nothing else leaning on the nerve. Some people can get small benign tumors that'll grow on the nerve or the nerves next to it and lean on it, or some other tissues in the brain which can sometimes form benign masses in there that'll start pressing on things. So we always have to make sure it isn't something else. We want to make sure it's not an aneurysm leaning on the nerve. There's something else wrong with the blood vessel, or there's some chronic inflammation or something wrong in the skull or the bones where the nerve exits to the base of the skull to come out into the face, that there's not some kind of chronic infection or tumor or bone disease that's causing this. So we always get a scan just to make sure it's nothing else. I mentioned earlier that multiple sclerosis can occur in younger people. That's not so much a lesion on the nerve because multiple sclerosis does not affect the nerves. It affects the brain and the spinal cord only, but can affect where the nerve plugs into the brain. It can hit you in the same area where the nerve now plugs into the brain. It's a brain problem, but it can give you very similar symptoms. But the nerve itself is okay.
And then once someone's diagnosed with this, primarily on symptoms, after you rule out tumors or things like that, then are there any treatments that are effective?
Oh, there's a lot of treatments, fortunately. Most of them are quite effective. But unfortunately, not everybody responds to treatments of this condition like many other conditions. First, we got to make sure that we don't have to go in and remove something or fix something for the neurosurgeons to go in and fix something and take something out to cure the problem. Although there is a neurosurgical procedure that actually does that.
So medicines, any medicines?
Yes. The most common one is a drug called carbamazepine, with the brand name of which is Tegretol. Now this came out in the early 70s. I remember because I was in training then. And it was
a
used,
seizure medication?
It became a seizure medicine. It came out first for trigeminal neuralgia while they were doing it. And it was the first major step and is still the gold standard treatment. It is still the #1 drug out there used for treatment of this disorder. A few years later, it got cleared by the FDA to use it for epilepsy too. But it actually started out life as a trigeminal nerve treatment. And people were scared to death to use it because it first came out that there was problem with suppressing your blood counts and your white counts and suppressing your bone marrow. And this was terrible and nobody wanted to use it. That does happen, but it's extremely rare, which is why we monitor the blood. I think I've seen maybe one person in 35 years that actually had a problem that we had to deal with. I mean,
so they take it every day, and that
yes,
takes
every
care
day.
of the
Usually
pain?
several times a day, although there's some
okay.
long-acting forms of it.
Okay, good.
You can take it every day, and depending on how you titrate the dose, some people get by on very low doses. Some people have to take very high doses of it to try to get it under control. And in a few people, obviously, it doesn't work, because some people, the side effects can be dizziness, nausea, unsteadiness, feeling drunk, that type of thing on higher doses. And elderly people don't tolerate it like younger people tend to, so sometimes that's a problem. But in the vast majority of people, that drug stops it.
So is that usually the first line treatment?
We almost always start with that one. Other anticonvulsants will sometimes do it. Depakote, Neurontin, or generic name gabapentin is sometimes used. Will sometimes in some people stop it. Dilantin has been rarely used. It was never very effective. But any drug that quiets down the nervous system, like seizure drugs, to prevent seizures, also will quiet down irritable nerve too. So a lot of those drugs are used, and often with great success. But there's a few people who are refractory. They just will not get relief with no matter how much medicine we give them, and then we have to come up with an alternative plan.
And what would that be?
Well, in the past they used to do injections up through the base of the mouth, up into the base of the skull, with needles to try to deaden the nerve, to stop the pain, figuring two wrongs make a right. So if we deaden the nerve, we maybe kill the pain, but sometimes you kill part of the nerve too, and many people were left with numbness on part of the face, which became permanent. If that's your eye, that's a problem, because you can get all sorts of problems with your eyes because you can't feel it. You can get little pieces of dirt or something in your eye that you don't feel that can cause all sorts of infections or inflammation. And people have been known to lose their eye because they can't feel properly the eye. They don't know when something's got in it.
So not using injections?
So that's rarely done anymore. Then they tried sound waves, trying to hit the nerve. They've done spinal cord injections at the base of the brain to try to catch a branch. There's a branch of the fifth nerve that comes down into the spinal cord. They try to hit it down there and see if they could sort of short it out from down below, which was somewhat successful, but had a lot of problems. Then about 20 years ago, the chairman of neurosurgery at University of Pittsburgh, Dr. Janetta, started doing surgeries at the base of the brain. And out of that evolved what they can now call the Janetta procedure, which they actually opened up the back of the head, opened up the back of the brain, and actually went in and removed the blood vessel off the nerve, put a little pad over the top of it, and let the nerve heal. And the success rate was extremely high. I mean, he claimed at one point almost 100% cure. But that's a major, delicate operation where you're dealing with very critical structures of the brain and the circulation, so you don't do those lightly. It works, and every patient I've ever had done on it years ago, this worked quite well, but that's a serious operation. And it takes people who are well trained in how to do the Janetta procedure. Not all neurosurgeons are good at that. So I used to send a lot of people to the University of Pittsburgh years ago to have Dr. Janetta himself, who is now retired, do it. But other people have now learned this technique, and this is now much more commonly trained in neurosurgery.
Is it done in this area, or do you have to go over to Baltimore?
Not by our local group.
Okay.
No, they'd have to go to Baltimore for that.
Okay.
But we don't use that one as much anymore either.
So what
but
do
it
you
works.
use? Okay.
So for the refractory people, we tend to use what's known as gamma knife irradiation. They can actually focus a beam very tiny, almost like a pencil point of focused radiation, right there on the nerve with the MRI, and focus it right in where that nerve is and give it a light zap. And blood vessels are extremely sensitive to radiation. And what usually happens is you melt the little blood vessel off the artery. And people think, aren't you going to cause a stroke? No, actually you don't, surprisingly. Most people don't miss that little blood vessel at all, because usually it's a minor vessel, one of the little side branches. So they melt that one off and the nerve heals. And the cure rate of this is actually very good. Now, occasionally it comes back. And once you've radiated somebody once, it gets tricky about radiating them again. The first time, there's usually no side effects. The second time, you often wind up with some nerve damage, because there's a limit on how much radiation nervous tissue can have. And I've had two people I've had done twice because the pain was just excruciating. And they got good results the first time, and then several years later it came back. So we re-radiated and got rid of it again, but now they're left with numbness of the face, which they said, it's a trade-off. I'll take it. Compared to the pain, I'll take it. And one of them is actually gradually shrinking. The nerve is gradually healing back, and the area is shrinking, but a large portion of numbness through here. And that's been very effective for most people. I mean,
But you're saying that's for cases that don't respond to the medication.
Or can't tolerate it.
Okay, all right.
For whatever reason. The side effects are too much and they're too drunk, they can't function. And yes, they got relief, but the side effects are as bad as the problem. And some people do not tolerate drugs very well, particularly the elderly. So we have to find another thing, so we go then for the cure. And I try almost all the drugs first before I would do that, just because it's a beam of radiation. And you always worry a little bit about late sequelae of any kind of beam of radiation. To my knowledge, there usually isn't any for this one. If we radiate larger portions of the brain, like for cancer or some other malformations, you can sometimes get some delayed effects. But this one's a very pinpoint little beam. It's like putting a pinpoint or a little laser beam right there on that nerve, and you zap it just enough to knock out the blood vessels, and the nerve heals.
Well, it's good to know there's some treatments that work for this.
And we can usually cure most people one way or another. Now, the two major ways, the genetic procedure and the radiation, are a little drastic, particularly the surgery. The surgery usually is a permanent cure, but it's a major surgery. There's risk involved in that one. When it goes well, it's excellent, but not all surgeries always go well.
Well, other than the extreme excruciating pain, it doesn't have an impact on life expectancy at all, does it?
No, only if people stop eating, or some people commit suicide because they can't take the pain. But outside of that, no.
Oh, okay. Well, but I'm just saying, but is it that people don't know there's treatments, or?
They know their treatments because they wind up going to the doctors. First, they go to the dentist primarily. They often.
So that's usually the first
when
person.
It's this branch, it's the dentist they go to, and the dentist frequently sends them to us.
Okay.
Sometimes after a few teeth were pulled, and in retrospect may not have needed to be pulled, but sometimes the teeth are so painful that the dentist will pull them because they figure they have no choice. And then we find out later that, because sometimes it's very focused right there in the teeth. We find out later it really is part of the neuralgia when it begins to spread, for example. But it often involves this whole area right in through here. It's the most common is the fold in the face right here, and the upper lip and the cheek are the most common areas.
Well, that's good to know. And that blood pressure, just keeping your blood pressure under control.
Lowering blood pressure. Once we get people in remission with the medication, I tell people we've got to really fight the blood pressure to get it down as low as possible, because that's the usual cause. All these treatments are much less effective for MS because that's a brain disease, not a neuralgia per se, even though it can affect the same nerve and cause pain in it, but the results are nowhere near as good in MS. You just hope for the MS heals and the pain goes away by healing it, because we can't use any of those treatments very effectively for MS patients.
Is it more common in men or women, or is it equally
No, I think it's fairly
distributed?
Equal. I think it's fairly equal. I haven't seen any statistics on that in a long time, but I think it's fairly equal. I can't say that I've seen in my years of practice a particular predominance of one over the other.
And no other risk factors?
Not particularly.
Okay.
I mean, I say high blood pressure is the most common. I mean, high cholesterol and sugar tend to lead into vascular disease, or heavy smoking too, being the most common. But high blood pressure tends to be the most, because it tends to distort the nerve and put a little more pounding in that artery to slowly work its way through the nerves. Because we have blood vessels leaning on nerves all the time, but they're not doing anything. But when the pressure goes up on a sustained basis, it starts cutting into the nerve and shorting it out.
Well, I imagine it can be very distressful to have this, and I know there's some websites that offer support and information for people, because I've heard this term before, but I really never knew exactly what it was and how painful it can be.
Oh, it's a miserable affliction. I say the upper branch of the nerve actually tends to be very common in shingles infection. You can get a bad neuralgia of that nerve from shingles, which is herpes zoster, the chickenpox virus. And if it's going to hit the face, that's the one it tends to hit, with these big blisters and red areas on the forehead and the eye, which is very painful, of course, being in the eye itself.
Well, I know most of us have heard of shingles and know how painful that can be. And you're saying this is
a common site is the first division of the trigeminal nerve of the eye on the forehead. It rarely hits the lower part. It almost always hits the upper part. I don't know why.
With shingles per se?
Yeah. That's a different form of trigeminal neuralgia.
Okay. Yeah, I was wondering if there was a connection with the shingles.
Yeah, because it can hit that nerve. It can hit any nerve in the body, but that's a common one.
Okay.
Well,
we'll post some websites at the end of the program where people can get more information, and I appreciate you coming in again to talk to us about this.
I'm always glad to come in and give more information.
Okay. And thank you for joining us for this edition of Focus on Health here on PAC 14.
Focus on Health is sponsored by Peninsula Regional Medical Center, a proud supporter of PAC 14 programming.